let's start talking about health information technology. Judy, you know, when we were compiling the glossary that everybody received, it was amazing to me how often the initials, the acronym ONC came up. The Office of National Coordinators all over the glossary, and I just want to commend you and the organization you represent for the great work you've been doing for these past few years.
Thank you.
Yeah.
So, little known fact, but when the initial American Recovery and Reinvestment Act, or the stimulus bill, was passed in 2009, the HITECH Act, okay, that you referenced, was part of that. And that is an acronym, which I'm hoping is in, I didn't check, in the glossary, but that stands for Health Information Technology for Economic and Clinical Health. Health Information Technology for Economic and Clinical Health. And that's an important part because sometimes we focus on the high-tech word, getting in the automation, and we don't focus on why we're getting it in for economic and clinical health, for health reform, right, for care delivery reform. So I want to point that out. But the second thing I want to point out, when that law was first passed, and ONC had already been stood up for a while. So ONC actually goes back to 2004. And I will tell you the acronym was different in 2004. It was ONCHIT, and when pronounced was ONCHIT. And so that had some obvious problems, and it was changed fairly quickly. But I thought I'd share that with you because as long as you brought it up.
So Judy, with all these things, these initiatives that the ONC is involved, and let me just give an abridged list: meaningful use, standards, interoperability, and then of course that gold standard we are all seeking is health information exchange. How important are these initiatives for the jail-involved populations and also for their providers?
So meaningful use, by its definition, the way it was set up, required certain providers that were eligible to achieve meaningful use and get the EHR incentive payments, and then others which were lovingly deemed non-eligibles. Not sure that's a really good term, but it's the opposite of the people over here. So the people over here, by design, were providers and were eligible hospitals, okay? And you had to meet a certain threshold of Medicare or Medicaid patients in either to qualify for the Medicare or the Medicaid incentive. And in the case of the hospitals, you could get both, and in the case of providers, you could just get one or the other. So if you qualified for Medicaid, that was a greater amount, so you went with that. So that program got everything started, right? And I think if you've been following this, a tipping point has really been reached in that particular space. So in the hospital space, we have 90%, as of the end of February, 90% of the hospitals that have received a payment from either Medicare or Medicaid for EHR incentives. Okay, big number. And another 5%, so up to 95%, have at least signed up for the program, even though they haven't received payments yet. On the provider side, the statistics aren't quite as good, but they actually are also quite good. 68% of providers have received a payment from either Medicare or Medicaid, and up to 85% total have at least registered for the program. So why that's important to this particular space, I think, is it got the momentum going, right? It got that tipping point where now we've got a bunch of people using electronic health records that takes the information that we need and automates it and provides the capability of moving it around. Okay, so they're maybe not moving it around yet, but at least has the capability. So let's think about what that means. What that means is if you were the first person to have an EHR and you wanted to send information to someone electronically, you wouldn't have any way to send it. So it's kind of like the early days of the telephone, which I know none of us can identify, but maybe we can identify with the first fax machines, right? You had a fax machine, but you had nobody to fax to, right? So even though you had the capability, you had to have the capability of faxing to someone. So the good news is that we're sort of over that hump, because what's starting to happen is that we're at least being able to pass information between those that were on this side eligible. But it creates the infrastructure for passing to these people as well. Now, everybody believes, that this is about the continuum of care and creating a patient-centric record and making sure that that Important information, whether it's the problem list, the medication list, you know, the last lab results, the blood pressures that might be important, the allergies, that information follows the patient wherever they go. And that's a really, really, really important concept. So I think what's happened for me is it's laid the infrastructure. And I know behavioral health is over here, okay? I'm well aware of that. It's like ding, 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 ding. So, you know, behavioral health is over here along with many of the correctional facilities. But at least we've got people out there with telephones and fax machines, okay? So if you can at least get the electronic health record in, you can begin exchanging the information because that infrastructure is sort of waiting out there. Now, that's a little strong, waiting. It's sort of waiting because interoperability, you know, we've just started this part of it, okay? So you may be familiar, I'm sorry, I'm probably talking too long, I'll go quick. Get the electronic health record in, start exchanging, improve quality. Those were really the 3 earmarks of stage 1 meaningful use, stage 2 meaningful use, stage 3 meaningful use. And in stage 2, we're just in the first year of stage 2. So when I emphasize that word, not everybody's able to move information around. And for those that can, oftentimes they bundle it up in a way that it's packaged almost like a document, like as if you had an attachment in an email, and it's sent, and it needs to be opened up and looked at, but it can't necessarily, in all cases, be consumed, if you will, or like actually update the electronic health record that it's sending to. So these are our early stages, but at least we're moving, and at least we get some data going around.
Well, what I'd like to just add on to it, sort of like the buds of spring right now. You're seeing little things pop up everywhere. So in my travels around the country going to different jails, like I was recently in Pima County, and they've actually brought in a portal from the Health Information Network of Arizona into the jail so that when at intake, they can look up and see someone's prescription medicine history. And then in Fayette County in Kentucky in January, they began to send event notifications up to the Kentucky Health Information Exchange, admission, discharge, transfer, ADT messages. And if you read in the Health Affairs blog with Dr. Brenner in Camden, his story about James, his asthmatic, and how he lost track of him because he went into the jail, and then his decision then to have the Camden Coalition bring in as a portal to the jail the Camden HIE. Of course, it's not back and forth, but it's a beginning. You're actually being able to pull information off of the Health Information Exchange. Judy, you know, Tom's in the auditorium, Tom Novak.
Might have to phone a friend, by the way.
Yeah, and when he was at CMS, he did something different. He changed a regulation that made it maybe possible that jail providers could become eligible providers in meaningful use. Can you just talk about that briefly?
Well, just that's beginning. And again, we could ask Tom to give more details on that. But it's pretty much linked, in most cases, I think, to the Medicaid expansion.
Yes.
Thank you. He's head nodding. And New York is a case in point in that they've started the journey and actually have probably about 1,000 physicians who would be eligible now because of the expansion. They can make the denominator, which is the important threshold to get in on the meaningful use eligible piece. So there's about 1,000 that can possibly do that, and the first 25 have gone through the journey and you know, kind of crossing over that hump. Don't think they've received their payments yet. That usually lags for a little bit from when you attest to when you get it, but it's an exciting beginning, and if they write up their story and talk about their story and help other people see how they can do it, that will be really powerful.
And what I've noticed throughout the nation is that for some jails this may be too high of a bar, but yet nevertheless, as I mentioned in my little speech there, is that many of jails are using meaningful use as a standard. They're letting RFPs that demand that the EHR meet meaningful use standards. So even if they never do a test, it gives them a foundation for them to say, okay, this is what we need in our electronic health record.
Yeah, and let's be clear, meaningful use is the floor.
Yes.
Okay, it's never meant to be. If a certified electronic health record, meets all the criteria, that it's the best EHR known to man. No, it's the floor. And so you definitely want to look at those that are certified, but then look at what else they have, because going up from the floor is going to provide that unique functionality, what differentiates our vendors and actually creates the market opportunity.
Yeah. Linda, again, congratulations.
Thank you.
As during all these panels, it's often been mentioned that a high percentage of the people cycling through our county jails have behavioral health histories, mental illness, substance use disorder. How does behavioral health fit into this widespread adoption of health IT?
I think it's front and center. So if you go beyond even people who are justice involved, 25% of all hospital admissions in this country for any reason have a comorbid either mental health or substance use disorder. So clearly it's front and center. I can't help but also add my congratulations to ONC, which I think has been a brilliant federal agency. I do have to say, however, as the left hand, that we do think behavioral health organizations, substance use, and mental health were left out of facility payments. Now, physicians and nurses who work in those settings can apply, but it is a very small amount of money, right? When you look at an organization and what it costs not only to bring an electronic health record into the organization, but to maintain it, because it's not a static purchase, right? It is changing all the time. It's an ongoing operating expense. There is a bill in Congress, right? The Behavioral Health Information Technology Act, in both the House and in the Senate. For anyone interested, I have the numbers. And we hope, those of you in the audience who are involved with people who are justice involved and have behavioral health disorders would support that. And just as we were able to move the Excellence Act, I am optimistic we can move that and begin to get some facility payments. So I think the other thing is, The Economist, for those of you that read it, a few years ago said there were 3 global trends. And it really stuck with me. And the 3 global trends, one was experimentation. And I think what we're seeing under the ACA is a wide range of experimentation. Actually, when Don Berwick was at CMS, he said, that's what we're doing. Whether it's health homes or it's ACOs, they're experiments in many ways. Even managed care, that wonderful panel that spoke right before us said, the jury's still out about whether that's going to save money or not, or even improve care. So there's a lot of experimentation. The second is a demand for impact. And that's what this meeting's about, right? We're all anxious. We're used to being able to go to Amazon Prime and get whatever we want when we want it. So we have that, and the third is technology. So I'm not a technology expert, but I'm a technology groupie. And health information technology, our vice president of HIT, Mike Lardiere, is here in the audience, and we invested in that position because we believe so strongly in its future, not only in terms of an electronic health record, but in terms of handheld technology that's going to extend treatment, help people manage their own problems, and really, as in all other industries, in some ways either extend staff or replace staff. So, long answer to a short question.
Well, Judy and I were just mentioning health information exchange. Could you talk briefly about extra consent that's needed besides the usual consent, especially for substance use disorder treatment?
Yeah. I don't know if Paul Samuels is still here. I feel rather inadequate when he has been here talking today about this issue. We know that there are, of course, the HIPAA standards. About half the states added additional restrictions even for mental health. And then, of course, there is the substance use side, and that's kind of the elephant in the room always. And I think, for someone like me who comes out of a mental health world and is an avid learner about substance use disorders, I don't think until recently I appreciated the issue around that. That extra protection is vitally important because in people's medical records who have a substance use disorder, they are in fact doing things that are a crime. And it is very important that that information not be easily accessible if they're going to have an honest relationship with the person who's treating them. So our hope is that some of the work that ONC is leading, whether it's data segmentation, right, the fact that healthcare facilities who are not specialty substance use organizations can notify when someone's come into, the emergency room, that some of that will help address this. I think privacy is an issue for all of us, right? I always say there is no privacy. I'm sitting on my cell phone right now. Everybody knows where I am, right? So I think this is a complex issue, and we have to find ways to solve it that don't hurt people who are trying to get care.
Judy, I know that the ONC and its standards and interoperability framework projects, one of the initiatives addressed was data segmentation. Would you care to comment a little bit about that?
So conceptually, just to let everybody know who might not have heard the term before, data segmentation is taking, and usually it's the patient that chooses to segment that information and put it over here and say, I don't want everybody to see that. So that when you're doing health information exchange, you can exchange all this other information on my primary consent. But for this stuff over here, I want to put it over here and require an extra consent for that data that is segmented. And it's certainly something for mental health, but it could be other kinds of things as well. So it could be that I'm concerned about a certain diagnosis that I have, and I'm applying for a job, and I'm afraid they're going to differentiate me because of this diagnosis. Or it could be that I had an abortion, 5 years ago, and I don't want my new employer to know that or somebody else to know. So there's other purposes, but certainly mental health is probably the biggest use case. But the idea would be that extra consent would be required for that segmented data.
Yeah, I know from my interviews with regional health information organizations and other such organizations who are implementing health information exchange, many of them didn't take into consideration segmented data. And so it's a very high bar for them to suddenly meet when they're dealing with so many other issues around health information technology and its exchange. I know that Steve Rosenberg and I were talking in the office one day about sort of a high-tech, low-tech solution, especially in light of Fayette County's event notification, and event notification is very much in the news, in the HIT news these days, is that maybe that can, when you get an event notification, maybe that can initiate an old-fashioned phone call or an old-fashioned fax to actually have the consent there, so we make sure that this special and important data that needs to be private stays private at this point in time, because you have to realize this is an evolving world and not everything's going to be solved, as you probably realize at this point in time.
At our big Health IT conference just in February, of the multitude of vendors that were there, there's just a couple that are actively working on this, and the electronic health record vendors. And one of them, though, actually does have a pilot going in Virginia at Inova Health. So I think we're going to hear and see more about this. And it's going to break, in the next couple of years.
Well, the same thing when you started with meaningful use. What was 10% of providers had EHR technology, and it was questionable what that 10% meant.
Right.
And now you have 70% because ONC.
And a lot of involved communities.
Homer, you're our boots on the ground guy down there who's actually been implementing all of this.
We're the mess.
You're the mess. Can you sort of talk about your experience with meaningful use at Rikers and testing and all the work your excellent staff has been engaged in?
Sure. I mean, so I think that Judy mentioned that we have 23, 25 attestations and the checks on the way. But I would, and we're privileged to have Rick Stazeski, our Assistant Commissioner of ITI here, and also Michelle Martel, who wrote that fantastic blog on health affairs, two key leaders in this area. So it's been slow. I mean, we started rolling out the EHR in the jails in 2008. You know, we got done with the rollout 2011, and then started thinking about meaningful use right away, and probably before that. And Rick has really been kind of pushing us to think about how we operationalize it. And so it's been slow. We had to, you know, we didn't know which of our providers are signed up with Medicaid, and many of them weren't. Remember, this is a correctional, it's a big jail system. We have, you know, 12,000 patients. We have 1,300 people who work in correctional health in different various forms. So a lot of those people, some of those docs and PAs and nurses work elsewhere, but many don't. And so this is new to them. The EHR was new to them 3 years ago. So it's been slow. It was a slow process to find people, get their permission. It was slow to negotiate with the union that they're part of, because, you know, you're not just dropping these payments into a vacuum. You're dropping them into a place where every year we have less and less money for this correctional health budget, where we're openly, you know, in very complicated negotiations, and then you bring in this notion of money falling from the sky, and everyone wants to know where it's going to go. Then we have the, you know, you have to show the Medicaid population that you have, that you serve, and so it's very tricky for having the statutory or regulatory changes that make us eligible. We then have to show that we serve Medicaid patients, and so it took us a while, but it looks like about 44% of our patients have active Medicaid, and so I think that's helpful for us to know, and so that's actually information that's being looked up on everybody coming in. But we had to say, okay, we're going to start looking today, look over a series of months, and then come up with the data to validate what we thought was our assumption. And then, you know, to complete these applications is slow, and it's the first time we're doing it. It's certainly the first time we're going back and forth, and we have a lot of things to redo. And, you know, this is a lot of work for any individual provider, but then to coordinate it for a large group is difficult. But, you know, we're really hopeful that this will be, as you said, is the floor. You know, we have a lot of other health information initiatives, but this gets our providers up to the basis where we all understand that this is our tool that we're going to then use together to improve patient care.
So part of the problem on this numbering thing that you referenced briefly was also bore itself out with nurse-run clinics, in that they see patients typically who are underserved and don't have insurance, and so they're not actively Medicaid patients. So part of the issue is, are they eligible for Medicaid? Because if they're eligible for Medicaid, you can count them even though they're not active Medicaid patients. So it makes this way of counting creative on the one hand, but difficult on the other hand, because it's not like you can go into a database and say, oh, you know, here's the denominator of Medicaid patients. And you, I'm sure, run into the exact same thing.
Sure.
Yeah.
And Homer, how much negotiations did you have to do with the state Medicaid agency, since we've been talking about state Medicaid agencies, and just because it was a new paradigm even for the state Medicaid agency?
There's been back and forth. I would not say that that's been like, you know, I think that this process has multiple small rate limiting steps, but none of them has been insurmountable. Most of this, because this is new for us and new for them, we just have to, every time there's a new question or a new, like something that comes up on an application, we go back and forth once or twice, but generally we've been able to resolve everything that comes up.
I do think state Medicaid offices and directors have been heroes in a lot of this, you know, and it's not just because I'm a former state employee, but I do think that what's come at them as a result of the ACA, particularly in Medicaid, has been just enormous. And they've had to juggle so many things and are trying to do so, I think, very skillfully. I don't always agree with their decisions, but they do have a lot on their plates.
And Homer, can you talk a little bit about your exchanges, not just with the different RIOs in the New York metropolitan area, but also maybe with psyches, and how you try to actually pull data on the individuals coming into the jail so you have a better background in projects?
We have 2 pilots going on right now. So these aren't things that we've operationalized across the jail system. So our jail system, we have 12 jails. And so what we've decided is in 1 or 2 spots to pilot both of these connections. And again, Rick and Michelle are really, and their teams are really the ones leading the way. So one is hooking up to the RIO, the Regional Health Information. So that's pretty self-evident. It's a traditional health information exchange, our EHR hooking up with them. When that's connected, when we turn that on, what we see is that we actually push out a lot of information that may be a little bit terrifying for people out there. There's our people listening, our people putting their information in, but you know, correctional health, for those of you who haven't like provided care in jails and prisons, is very process oriented. So you have lots and lots of encounters. All of our medical care, mental health care, substance abuse programming is on our EHR. It's all integrated. We write 5,000 to 7,000 prescriptions a day. We have, you know, tens of thousands of encounters every month. And so to take, and we haven't gotten good about problem lists, so we have huge long problem lists. And so when you take a system like ours that is so process heavy and then just zap that stuff out to the community, I think it can be pretty overwhelming. So we have the connection made. We're thinking really hard about how do we improve our workflows to most benefit our community partners. And then also, you know, that information coming back to us. I think the information coming back to us is going to be very helpful for mental health care. And that also dovetails nicely with the other pilot we have, which is through a partnership with the State Office of Mental Health, we have access to Medicaid claims data. So it's a completely different data, but it's incredibly useful when we're thinking about people with serious mental illness, people who have complicated medical regimens. We're able to see very nice data going back over time about what types of treatment, medication doses, places they, you know, that build for their care. It gives us good continuity because mental health, you know, if we do 80,000 admissions a year in our system, probably about 20,000 people will come into the mental health service. And those people, during their mental health intake, we want to know, it's very important to us to know the trajectory of their care in the community. And so this Medicaid claims data, I think is actually going to bear fruit for us early on. I think that the RIO and the traditional HIE connections, we have work to do with us and our partners to think about how do we sync up what we're giving each other. Because remember, if you're a provider, it isn't, you know, jail-based and prison-based healthcare is often process-oriented. It's hard to build continuity, and so it's hard to ask providers to do more in an individual encounter. Certainly, you're not going to ask them to look at 40 or 60 or 100 documents that are sitting there on the health information exchange. So we believe that both of these are going to be helpful for our patients ultimately, but we have a lot of work to do now that we've turned on these connections.
You know, Homer, on a slightly different track is that you've often spoke and written upon the subject of human rights and electronic health records. It's a very interesting idea. Can you go into that more fully?
Yeah, that's the thing about the EHR that makes me smile and feel great. I'm a primary care provider and at times have been over the years a little agnostic about the EHR and the virtues it brings to our patients. But we, about 2 years ago, committed to our own triple aims in correctional health. And the triple aims for us in correctional health are patient safety, population health, and human rights. And we think that if you don't do those 3 things, and if you don't tend those 3 missions, then you will fail your patients. So patient safety is good policies, well-trained providers, credentialing. Population health is using the tools of epidemiology to look at trends of what's going on with diseases, infectious diseases. But human rights is the notion that there are particular special pressures on your health mission in correctional settings that are different from other places. So the one we talk about and we train all our providers on, everybody gets trained on, is called dual loyalty. And that's the notion that your health mission, the second you pick up a stethoscope or a blood pressure cuff, if you're in a jail or a prison, there's pressure on your health mission that comes from the security mission. And most of the time it's small, and most of the time it doesn't lead you to do anything you shouldn't do, but it's there all the time. And it can be very little, like somebody suggesting you don't give somebody an order for a cane because maybe they shouldn't have a cane, to very large, which is what do you do if you're a health provider and you see somebody getting beaten up or somebody tells you something that happened to them. So we think that if you don't incorporate human rights into your correctional health mission, then you could do the best job at patient safety, you could do the best job at population health, but ultimately you'll fail your patients because correctional health settings, correctional settings are places where abuse happens. And the question is not, does it happen? The question is, does it happen a lot or a little? And do you know about it or not know about it? And do you talk to your providers about it? So the EHR has been the most amazing, impressive, fantastic tool for promoting human rights that we can, that I can imagine. We just published a paper in AJPH about the link between solitary confinement and self-harm. So we noticed over years that the acts of self-harm, the acts of people hurting themselves in the jails, doubled. We also noticed parenthetically that the use of solitary confinement doubled. So we went and took 250,000 admissions, created all the predictive variables that we could think of, did a regression analysis, and lo and behold, we found that being seriously mentally ill, being an adolescent, or being ever in solitary confinement were all highly predictive of hurting yourself. And that's important because we think that our job in the jails is not simply to clean up the mess and to tend to pre-existing health problems. It is to document the ways in which the jail system hurts our patients. These are our patients. And so when they come back to you all in the community, and when an insurance plan or a health home or whoever picks them up on the outside, if they have a new traumatic brain injury, or if they have hurt themselves, or if their GAF has gone from 80 to 20, and it's because of something that happened in the jail, you all should know about it, because correctional health systems will not be always empowered to affect the change that their patients need, and we need help from the outside. And so that's one of our big hopes for the ACA, is that as we use our data smartly and as we incorporate human rights, we can communicate to the world, look, these are the things that we do to help people with their pre-existing problems. These are the things we do to clean up problems that happen in the jail setting, so help us fix those.
You know, can I just add something? That was beautiful, by the way. So if people wanted to clap, really, that was amazing, amazing. And I want to piggyback on it because I think to a lesser degree, the HIT and the EHR has that potential for mental health and substance use disorder treatment, which has long taken place behind closed doors, without the use of instruments to measure progress or lack of progress. And I think that's going to become transparent now. And we have the potential also to use those kind of algorithms to really chart a course for better treatment and to act as decision supports for clinicians. So I think that's transformative, and it's just what you said is perfect.
So I need to weigh in here too, because so health information exchange, a lot of times when we talk about it, we're talking about for concurrent patient care. We have a patient in front of us and we want to know what happened to them before, when they were on, outside of the facility, or when we're sending them outside of the facility, so that there's continuity of care. But another big purpose of health information exchange is retrospective data analysis. Right. So you were talking about analysis within your facility on the same EHR. But imagine the power if you could start aggregating data in cities, in communities, and in states, and across the country, where we actually take important pieces of information and aggregate them overall, so we can start to see, again, what's working, what's not working, and discover new evidence through new research in a way that we never could before. Because we don't have to do retrospective auditing of paper charts, we can pull pertinent pieces of information. Now I'm making a giant assumption here, and that's the assumption that we have standards so that we can aggregate the data. But imagine the power of aggregating that data. So when you hear people talk about learning health system, that's really what we're talking about, where we can iterate ourselves and understand what works at a pace that we were never able to before, once we get electronic health records that are interoperable and can do this data analysis across larger populations. And then we can turn around, and it's even better, because we can change care in a way we could never change either, because we have order sets and clinical decision support and documentation templates, so that once we learn something new, we don't have to try to tell people at conferences like this and do publications. We bake it right into the electronic health record. Yep. Yeah. So it's really an exciting time in this industry. Yeah.
Extraordinarily exciting.
Thank you all, and I want to just make a couple of observations here before we take it for just a very few questions. The first one is that part of what COCHS, as you all know, has been involved in this HIT thing from the very beginning, and part of that has been our perception that as long as what goes on behind bars is hidden and not integrated within the community and not accessible, then we're not doing anyone a service. So I think the promise of HIT is to remove that hidden aspect of it. And I think it was really exciting for me to hear Rich Lucia talk about their philosophical commitment, because if you're running a good shop, you don't want to hide anything, right? The only folks that want to hide something are the folks that have something to hide. And I think that's a really important issue, and it's one you struggle with every day, Homer, in terms of some of your union folks, of which we had a most recent unfortunate death, with a good example of someone that had something to hide. And I just want to point that out. We have time for